Dr. Ashish Rai is Director of the Pulmonary Arterial Hypertension Program at the Valley Hospital. Dr. Rai completed a Bachelor's of Medicine and Bachelor's of Surgery from Dr. D.Y. Patel School of Medicine. He completed his residency in internal medicine in 2019 from Mass General Brigham Salem Hospital and a fellowship in pulmonary and critical care from NYU Long Island Hospital. Dr. Rai has an office in Paramus across from the hospital. Thank you so much for joining us, Dr. Rai.
Thank you, Parminder. I would like to get started by welcoming everyone, and thank you for joining this evening to understand more about pulmonary hypertension. And as Parminder mentioned, if you have any questions, please feel free to ask at the end of the talk. And the purpose of the talk is to go over what pulmonary hypertension is and understand it from a very basic perspective. And I've tried to address most common questions that my patients or their loved ones are asking. And hopefully the presentation will walk you through some of those questions that you might have or you might be thinking about if one of your family members have pulmonary hypertension or are being treated or being diagnosed with pulmonary hypertension. So with that, getting started. So what exactly is pulmonary hypertension? It's in simple terms, pulmonary hypertension is a high blood pressure within the vessels of the lungs. And when you look at what is high, what it means is that when the average cutoff for normal blood pressure in the lungs is around 20 millimeters of mercury, which is measured through various diagnostic measures. A lot of times when I mention to my patients that you have pulmonary hypertension, the question that arises in most people's mind is whether pulmonary hypertension and hypertension, which a lot of people are familiar with, are the same or not. And hypertension is essentially a high blood pressure, which a lot of people have, and it's very common as you age. And it's the high pressures within the arteries that are supplying blood to your various organs. However, pulmonary hypertension is very specific to the arteries within the lung. And if the pressures within the arteries of the lungs are high, then you are defined as having pulmonary hypertension. And then the next question is whether you can have pulmonary hypertension and also have systemic hypertension. Yes, both can be present in somebody who is suffering from high pressures within the lungs and high pressures within the different organs or the vessels supplying these organs. And it could be vice versa. You can have pulmonary hypertension and not have systemic hypertension. The reason this is because the way your heart is designed, there are two different types of vessels that originate from the left side and the right side of the heart. And pulmonary hypertension primarily involves the right side of the heart. So when I'm explaining this to my patients, what I tell them is to think about it as in the terms of a pump that is supplying blood to your organs via pipes. And there are two different types of pipes. One pipe is coming from the left side and one pipe is coming from the right side. If there is an issue on the right side of the heart or the pump, and the pipes on the right side of the heart are blocked or have high pressures within themselves, then you have pulmonary hypertension. Whereas if you have issues on the left side of the heart and the pipes are blocked on the left side of the heart, then it's mostly related to your systemic hypertension, which a lot of people have because of aging. Your vessels get stiff, and that gives you more of a pulmonary systemic hypertension. And what exactly is pulmonary hypertension? It's the narrowing of blood vessels going from the heart to lungs. This is just a schematic taken from Cleveland Clinic where you have somebody who has normal arteries, or the right side of the heart here is depicted in blue color. Your blood is coming in and being pumped out from the right side of the heart. And if your diameter or the size of the artery is normal and there is no blockage within the arteries, then the blood can pass through easily. Whereas in pulmonary hypertension, there's a narrowing of your blood vessels and the blood is having a difficult time passing through, and this causes a rise in the pressure. Similar to the analogy of looking at it as a pump, if your pump is having difficulty in pumping any fluid out because of the pipes being blocked, then your pressure rises within that. And here in the picture, we can see that the blue side is what is going into your lungs. And if your pressure within the blue part goes high because of the narrowing, then that is defined as having pulmonary hypertension. Whereas you're talking about hypertension or systemic hypertension, is you're talking about the red part of the heart, which is the left side of the heart. And how do people usually present, and what are the common signs and symptoms to watch out for? The most common three-sided signs and symptoms are shortness of breath, where most of the patients tell us that they are not able to catch up on the breath. They were able to walk certain distances or walk up a hill or go on a hike 6 months ago, but over the past 6 months or a year or 3 months, that same hike or walking the same distance, walking the dogs have been very difficult, especially they notice that going uphill or keeping up with the children, keeping up with their friends has becoming very difficult. Some people also notice palpitations, which a lot of people explain as skipping up of heartbeats. Some people also do complain of loss of consciousness, which can be a red sign in pulmonary hypertension. These are three common signs and symptoms that people present with. And although these are generally very weak symptoms and can have been with other conditions also, but which can cause different types of issues with breathing. But pulmonary hypertension patients usually have all the three in common. And which patients can get pulmonary hypertension? Some of the predisposing conditions that are there are autoimmune conditions where unfortunately your body is not able to recognize between the normal and the abnormal cells and starts to attack your normal cells. And some of us might have heard about conditions like lupus, Sjogren's. Often patients have joint pain, swelling, and skin rashes. And then you have the most common form where you have underlying heart conditions where your valves can be floppy. And that is why the pressures goes up in your pipes or the valves or the vessels that are coming out of the heart. And the two most common other causes are ischemic cardiomyopathy, or in other terms, happens because you have a blockage in your heart vessels. You have a chronic ongoing blockage of your heart vessels and your heart function goes down. And that leads to less blood supply to your heart muscles and the heart muscles become weak. And now because of the pump being weak, your pressures unfortunately go up in your vessels. And then there is something also called non-ischemic, which is not related to blood supply of the heart, but is related just because the heart is not able to relax. The heart as a pump has to relax so that it can get enough blood in and then have the capacity to pump that blood out. So if the heart is not able to relax, it tends to build up the pressure back into the pipes. And then some people unfortunately are born with some defects in the heart, which is in common terms known as a hole in the heart, where you have a hole in the top part of the heart known as the atrial septal defect, or a hole in the bottom part of the heart. And sometimes the vessels are not aligned properly, and these people tend to have pulmonary hypertension. Then the third category is when patients have COPD and have been diagnosed with COPD, or they find out that they have COPD if they have pulmonary hypertension. And then the other part of it is also when patients have other underlying lung disease. One of the most common causes that are coming out is obesity, hypoventilation, when patients are not able to breathe at night, and we need to help them with something called a sleep mask or a sleep apnea. And I think that has become very common. People are diagnosed with sleep apnea, and that is one of the reasons that can be treated, and the pulmonary hypertension can actually get better if you treat the underlying sleep apnea or the obesity hypoventilation. Some patients do tend to form more clots than other, and they are predisposed to forming clots. They have a family history where somebody in their family had blood clots early in their lifetime, and now they are having blood clots, which starts usually in the legs, and they tend to migrate into your lungs and become a pulmonary embolism. The other rare causes are sarcoid, which is another type of an autoimmune condition but has been linked into group 5 or other causes. And then another common cause is your sickle cell, where your hemoglobin or the molecule that carries oxygen in your blood is deformed. And then there are also, we groups of patients who we are unfortunately not able to find the exact cause in today's age, and we don't know exactly why these patients have high pressures within the lung. So these are just broad categories of the types of conditions that people can present with, which can predispose them to having high pressures within the arteries of the lung. And the most common way of finding out if you have pulmonary hypertension is an echocardiogram, which is like an ultrasound of the heart. On the left side is a depiction of a high pressure within the right side of the lung. So what you're seeing on the screen is the blood that is actually flowing back into the top part of the heart, because the right side of the heart is much more bigger than the left side. Usually we are all born with the left side of the heart being big, because the left side of the heart is the one that supplies blood to different parts of your bodies, to your brain, to your lungs, to your stomach, to your every other part. So it has to do more work, and that is the reason why it's much more bigger than the right side of the heart. And unfortunately, if your pressures tend to become higher, over here, the right side is flipped, and on the screen you can see it on the left side. So it on this here where it's showing the high jet, your right side of the heart has become much more bigger, and this person unfortunately has pulmonary hypertension. This is a normal depiction of how the right side looks, much more smaller and more of a cone shape, whereas the on a patient with pulmonary hypertension, the right side of the heart gets much more bigger. The echocardiogram, or the ultrasound of the heart, is usually a screening tool. If you go to your doctor and tell them that you're having shortness of breath, this is one of the tools that your physician might use to figure out what is happening and why you're having the breathing issues, apart from other tests that they might order. The other diagnostic or the confirmatory test that we very often perform in the hospital is right heart catheterization, which is a minimally invasive test, and most commonly it's like putting in an IV line or a IV catheter, or getting blood tests when you're getting a blood test done from on your right elbow, and you come into the hospital. The procedure is usually 20 minutes, and you get to go home the same day. It gives us a lot of information in terms of how high exactly your pressures are within the right side of the heart, how what is the function of the heart muscles itself, and where exactly is the lesion, or where exactly is the blockage within the heart. A lot of times people ask me whether a right heart catheterization is same as undergoing an angiogram, which people have heard about. Uh, Both these tests are very different. When we are talking about right heart catheterization, it's a much less invasive than undergoing an angiogram where you're shooting in dyes. There are no contrast, no dyes that are involved with the study. Uh, Very less side effects. The only side effects is the pain, and some people tend to get some bleeding, but their risk is much less compared to undergoing an angiogram where you're looking into the blood vessels that are supplying the left side of the heart or the muscles of the heart. And then another test that we have started doing at Valley is called an invasive cardiopulmonary exercise testing, which is a composite endpoint of different tests where we have patients who have a catheter while they are sitting on a bike and exercising, and we are trying to see how high their pressures are going. We are fortunate at Valley to do these tests because not a lot of centers has this capacity of doing it. And we are the second center in New Jersey that have started doing these tests. And the information that we get from this test is how your lungs and heart are performing when you're exercising. Because a lot of times our patients complain that they feel fine when they are resting, but when they try exercising or they try doing anything more than the usual, they tend to feel more short of breath. And we try to stimulate that same thing by having them exercise on a bike and measure what their heart and lungs are doing at the same time. This is again a same day test. You come into the hospital, the test takes are approximately about 40 minutes, and then you get to go home. And we are there, we tell you what the test was about, and we are able to prescribe you medication based on those tests. Some of the other tests that we might perform, depending on what is your predisposition for getting pulmonary hypertension, is a breathing test. which is a pulmonary function test where we ask you to breathe in and out. There are blood tests which can be performed to look into if you have those other predisposing conditions. And then there are cardiac MRIs to look at the structure of the heart. Not everybody needs to undergo all these tests. It all depends on what your predisposing condition is. And then there's VQ scan to look for ventilation perfusion scans to look for clots in your lung. If you do have a history of having prior clots or you have a family history of having blood clots. And going into what are the treatment options for pulmonary hypertension, we have a tailored approach and a very individualized treatment plan for every patient. There are different oral medications now that are out there. Over the past 20 years, we have been lucky to have approximately around 14 different medications that have come out in the past 20 years. And the field has grown a lot, and people are noticing a lot of benefits from all these medications. The medications are divided into four big classes, and going from calcium channel blockers to PDE5 inhibitors. And all these medications are taken orally. Some of them are taken once a day, some can be taken 3 times a day, depending on what type of pulmonary hypertension you have and how high your pressures are. Apart from oral medications, we also have another way of delivering the medications to your lung. If you have pulmonary hypertension that is specific to your lung itself, especially in patients who have COPD or asthma related to pulmonary hypertension or similar to the asthma that causes you to have pulmonary hypertension, then you can be on therapies where you can have the medication in a nebulizer and you can take the medication delivered directly into your lung. It comes in 2 different forms. One is a nebulized version on the left side of the screen, and on the right side, there's a small inhaler which you can carry around with you. And the medication has to be taken at least almost 3 to 4 times a day so that it can achieve a specific concentration in your body. And usually these medications are very well tolerated. Some people do have some cough, which goes away with time as your body gets used to it. And then the other form is also a continuous infusion therapy. It is very similar to insulin pump, which a lot of people are familiar with. The pump is something that can be held in your palm of your hand. There's a remote that comes with it, which tells you how much medication is infusing. You can hang the pump. The medication is within this small pump, which is battery controlled, and it hangs around your waist. And this is how the medication is delivered by a small plastic device that is sticking to your skin and is continuously delivering the medication via a small pump. Not everybody requires this medication. Depends on how severe your pulmonary hypertension is and whether you would benefit from this medication versus oral medication or infusion therapy. Most recently, this is the newest medication that has been approved in the past 2 years, which is an injectable form of medication which patients can take at home under the skin every 3 weeks. Again, this medication is also not for everybody with pulmonary hypertension. It depends on what type of pulmonary hypertension you have. And if you have a specific type of pulmonary hypertension that this medication has been studied in, then you can be prescribed this medication and get benefits from this. What should we expect once you are on treatment? The most common thing that you see within the first couple of weeks is that you notice a marked improvement in your breathing, which we tend to measure when you come to our office by making you walk for 6 minutes and see how much distance you are walking. Most patients tell me that when they are at home, they are able to do more things. They're able to go upstairs, they're able to do more laundry, they're able to go to a grocery store and participate in activities with their friend. We do tend to repeat these blood tests. We tend to repeat the right heart catheterization on an MRI to objectively measure how your pressures are doing, because we want to be on top of the condition that you have and then treat it aggressively so that we can give you the maximum benefit from the medication. The reason we do this, and this curve is, these graphs are a little bit too complicated to understand, but what this is showing that if we are more on top of our treatment regimen and we are more aggressive upfront, there is a mortality benefit, or people tend to live longer the more aggressive we are with the treatment. And this has been shown across different registries. These are the Reveal, Compare, and these are different registries that have been obtained across different continents, from North America to European continents and French registries. Everywhere it has shown that every time you try to upfront treat pulmonary hypertension and lower the pulmonary pressures or the pressures within the vessels of your lung and lower the resistance to the blood flow, people tend to live longer and have less breathing issues. Wanted to give you an overview of our pulmonary hypertension team. Apart from me, we have a total of 5 other people who are part of the team. We have Dr. Suraj Shah, we have Dr. Samit Shah, and Dr. Carrie Ann Abbott. We are a team of pulmonary and cardiology specialists who work together as a team in evaluating your condition. And then we have Emma Goebel, who will be starting as our Pulmonary Hypertension Center Director, and we have Jackie, who is helping out with day-to-day management of our Pulmonary Hypertension Center and making sure everybody is on top of the medication and coordinating with all of us. And with this, I would like to end the presentation and open the floor for any questions.
Great. Thank you so much, Dr. Rai, for that really informative presentation. Okay, I have a question. Do you see any role for AI or wearable devices in monitoring pulmonary hypertension symptoms or treatment effectiveness in the future?
That's a great question. There has actually been a lot of studies, and especially the Apple Watch that a lot of people have, where they have measured your heart rate, and there are other ways of measuring how active you are, and how many steps you're taking a day to see the response to the therapies that we are providing, that has shown equivalence or the same importance to doing a 6-minute walk test or repeating some of these tests.
Great. Another question. Are there any emerging treatments or procedures that are showing promise in clinical trials?
Yeah, and so with the injectable therapies that we were talking about are the most recent development in the past 3 years. Over the past 20 years, a lot of the focus was on trying to lower the pressures within the pulmonary arteries, but now the focus has changed to modifying the disease process itself. You've been hearing about different medications also targeting different diseases, which are becoming much more specific to the particular condition you have, and trying to not just elevate the symptoms, but also work at the root cause. That is where pulmonary hypertension is now moving into. Winrevair, or the injectable medication, was the first that came out 3 years ago, and there are 4 other medications that are in the pipeline that are either in the process of getting approved or in the late phase clinical trials, and should be seeing the market in the next 2 to 3 years and coming out and helping people. And I think I see that in the next 20 years, probably we'll have medications that will be actually modifying the disease rather than just controlling the disease itself.
It's amazing. So I have another question here. Are there any support resources or networks you can recommend for patients or families coping with a new diagnosis?
Yeah, no, that's a great point. And at Valley, we are setting up our own social support network, which will be virtual and in person, where it'll be a safe space for patients and their loved one to come in and share their concerns and voice what they are going through, because this condition is something that people live with and have and their families are going with them, and they can sharing their concerns, and their family's concern is we want to provide them with a platform where they can feel safe, join in virtually, which would be led by one of us, and they can share the common experience, because a lot of the experience that patients and the families have happens outside the medical world in the day-to-day lives and how they're coping with, and we tend to learn from each other and gain from each other's experience.
And you said that's coming, right? That's still going to
That's
be
coming, and that's in the pipeline. We're hoping to start it in January, second week.
okay. So just for those of you who I don't know if you've been looking at the chat, I did put a listing, a URL, www.valleyhealth.com/events. So once this support group is up and running, we will have it listed on that website. So I just wanted to make sure that if you're interested in learning about that further, check back in January at that particular URL. I have another question here. I am taking medications for high blood pressure and they are effective, but I find that they cause me to be very lethargic and dizzy at times. What should I do?
No, that's a good point. I think if you are taking some medications and you're noticing side effects from the medications, which should not be there, I think the best thing is to ask your physician if those medications are too much for you. Sometimes some of these medications can lower your blood pressure, and usually we tend to monitor our blood pressure at home. And when you go to see your physician, they check your blood pressures in the office itself. But if sometimes these medications might be too much for your body to handle, and the dose of these medications can be down titrated, sorry, or stopped if you do not need these medications.
Great. Another question. How much do genetics or family history play a role in pulmonary hypertension risk?
It's a great point, and the one of the common reasons for people to have primary pulmonary arterial hypertension is family history. If you do have, especially the pulmonary hypertension, when it was initially defined, was defined in patients who have family history of having pulmonary hypertension in the typically in the women part of side of the family, and they tend to have a higher predisposition to getting pulmonary hypertension. Females tend to get pulmonary hypertension more than males. And if you do have your direct relative who has pulmonary hypertension or blood relative that has pulmonary hypertension early in their life, there are risks that you can develop pulmonary hypertension. Not everybody who has a relative does get pulmonary hypertension. There are genes that have been discovered. There are carrier states that have been discovered specifically that cause mutation down the line. And these patients and their family, unfortunately, tend to have more predisposition to getting pulmonary hypertension.
Great. I'm just looking to see if there are any other questions. So is there any one misconception about pulmonary hypertension that you wish more people understood?
Yeah, no, I think one of the common misconceptions that I do attend a lot of times people have is about trying to think of it as a high blood pressure issue. And I think that because hypertension, a lot of people are aware of, and they know what hypertension is because they have suffered from it, they're suffering from it, or they have had somebody within the family or the friends have hypertension. And a lot of times people ask me this question that I am taking medications for high blood pressure, and those medications should be the same for my pulmonary hypertension, and how can I have pulmonary hypertension and high blood pressure at the same time? And I think that is something that we tend to explain to our patients, that pulmonary hypertension is separate from hypertension itself. You can have both or can have one or the other. And hypertension is much more common. Pulmonary hypertension is not that common to happen. And if you do have pulmonary hypertension, the medication treatment is very different than hypertension medications that a lot of people take.
Excellent. And then I see one more question here. How do you approach treating pulmonary hypertension when it's caused by another condition like heart disease or autoimmune disorders?
It's a great question. And I think it's a team-based approach where we try to work closely with our rheumatologist and with our heart specialist in trying to work in a two-pronged approach. We address the autoimmune condition. If you have lupus or you have Sjogren's or if you have rheumatoid arthritis, we work with our rheumatologist to make sure that you're on the correct medication for that. At the same time, we try to lower your pressures using all the other medications. Because we want to address the primary reason what is giving you pulmonary hypertension, but at the same time, we also want to lower your pressures. Because it has been shown that when we approach it as a team-based approach, you tend to live longer and you have less symptoms.
Great. And then with all the changes and recommendations in the last few years, what is the ideal blood pressure now?
I think the ideal blood blood pressure or the pulmonary artery pressure is so the diagnostic criteria is anything above 20. When we are trying to treat our patients, what we are trying to do is use different tests and different parameters to make sure that you fall into the low risk regimen. There is no one specific targets that we are looking for. You have a target for your blood pressure where we say that your blood pressure should be less than 130 for you to have less chances of having stroke or less chances of having a heart attack. But for pulmonary hypertension, it's a little bit more complicated because we are trying to fit in different parameters and different tests to make sure all these numbers are within the same range. And we have a calculator that we work with and try to get these numbers down. If you had to look at one particular thing, it would be looking at how much is the resistance within the pulmonary vessels itself, which we calculate by measuring your pulmonary artery pressure to the right heart cath. And every time we use these medications or try to up titrate or change these medications, we are trying to go down on that mean or the average number.
Great. And I don't see any more questions coming in. So I just want to take this moment to thank you, Dr. Rai. That was a very clear, concise, educational information about pulmonary hypertension. I want to thank you for taking time tonight for presenting to the community.
Thank you very much. Thank you, everybody, for joining in.